And he just come back, and we got out of detox. He's like, they gave him Librium, and he's kind of sedated in the outpatient group, but he's just out of detox. So he's sort of like, how do we do the questions are all like, sort of, how do we bring him back in with this situation? I assume it's probably individualized, but if you have a protocol, I would love to hear it. And in particular, because this guy had been sober a long time before then having a really bad recurrence of alcohol use. I was wondering, like, what would be the sort of the protocol? There's probably not a protocol, but sort of like what would be the general consensus on when he might be able to return to the intermediate group, where he had like 200 and some days sober prior to this. Also, I'm curious how other folks are using acamprosate disulfiram, and this patient's very interested in pregabalin, which has helped him in the past for alcohol maintenance treatment to prevent recurrence of use. Try to get away from using the word relapse. I also want some feedback on that. Also, I'm curious about, at the COPE program, if there are folks that are repetitively drinking but do not qualify for inpatient, because this particular patient, they kept not refusing to put him in for a detox, and like if that would have continued, and I think it would have had he not had a history of DTs, would you guys just keep an I code or AP code indefinitely in that situation? All right, so I'll start with the case. It's a 40-year-old. He just came back, I think, on the 23rd, 3 days ago, from the inpatient detox. But prior to that, it was 220 days sober, and he had, well, really for 15 days between the time that he had the 220 days sober, he had been just drinking a lot. And I think that's why no one wanted to put him into detox, because it was a brief period of time of drinking. What happened is he had left his recovery home where he had racked up all those sober days and returned to a very, very heavy history of alcohol, because he felt that no one cared that he left, and he didn't feel celebrated. So he was drinking like a pint right away out the gate, and then like a gallon at a time of liquor, really very quickly within a week of leaving the recovery home. He did have a remote history of DTs, and like 10, or I think he said like 16 history of alcohol detoxes in the remote past. And when I was seeing him in clinic prior to him going detox, he said, I can't stop drinking. I can't, if I stop, I can't handle the emotional status. And so by the time I finally got him to go inpatient, finally got him in after he'd been refused a few times, he was coming to the clinic drunk. But the first time I sent him for a detox, after like he'd only been drinking for a week, and when he went for medical clearance at the hospital, he had elevated troponins, I guess from where he was trying not to drink, and they had a negative heart cath. And then after they give him negative heart cath, they said, well, you've only been drinking for a week or two, you cannot need detox. So they just sent him home and gave him thiamine. So we treat him as AP MAT, but he kept drinking again. And I did a very extensive counseling on I actually showed him how to do his own CWA score at home, and if he felt like it got too high, to go back to the hospital. But then he needed to abstain from drinking and be treated as an outpatient. He attempted to abstain, and the CWA score went very high. He called EMS. EMS came out. They refused to take him to the hospital. They said it wasn't bad enough. So the next time he came back, and I will admit, in EMS's behalf, like he could hold out his hand and it was barely shaky at all. It wasn't very obvious that he was anxiety ridden, even when he had the elevated troponins, but he was saying internally he would have extreme anxiety, and he couldn't get out of bed without alcohol. And so he came after the EMS refused to take him to the hospital with a breathalyzer of 0.12 to us on July the 20th, at which point we were able to find somebody that would take him without a medical clearance process. And a recovery coach was going to drive him, but I think he went home first, and then we got Ubered him over, and he had spent 3 days at a place where they would not let him have Suboxone, only Librium. So then we came back to us on the 23rd, and we don't have the hospital records. We just have positive benzo drug screen in his report, and we know that Uber took him there. He was saying that he felt much better. He felt like he could go without drinking, but he was having opioid cravings again, pretty bad, where the Suboxone had been held. So we just restarted him back at the full 16 milligrams he had been on and stable for 220 days prior. But with a lot of warnings. He says, I was kind of nervous. He was very sedated. I kept him out of group with that Librium. I was afraid putting it as an outpatient Suboxone, especially at the full dose right out the gate. I told him to take it very slowly, just like a couple milligrams at a time as he's getting restarted, because I was afraid, I don't know what the danger is for that situation. That's why I'm presenting this case. And that was on Friday. Then I restarted on 16. And then this morning he returned looking pretty good. He was alert. He was saying he's having alcohol cravings, but he feels the Librium's wearing off. He's feeling that internal anxiety getting really bad again. He did agree to a Camprosate being added on when he previously had refused to add it on prior to the hospitalization. And he is going to come back tomorrow because he wants to get managed for pain. He has sarcoidosis. He also has some really, I can't even remember the name of it. Is this as a thoracic spinal, painful thoracic spinal disorder, which he wants. We have a pain management specialist that comes here on Tuesdays. So hopefully that'll help. But I think he's going to be wanting Lyrica at that appointment. And so that's also one of the things I wanted to address today. He had been on it in the past. So as infectious disease screening is all negative. He has I'm going to skip all this so that Dr. Hirschler can do a full talk, but basically he's used everything. But his biggest problem substances are alcohol and opioids, obviously. When he left the recovery home, he moved in with one of our female patients who seems to be staying sober and was really kind of pushing us to help him get inpatient. And was very concerned about him. I don't know much about the details of that relationship. He also has a weak connection with his mom, but is estranged from his ex-wife and 17 and 18-year-old sons. I think he's a lot alone. His family history is his father was an alcoholic, history of trauma, physical abuse as a child. His paternal uncle was diagnosed with schizophrenia. I've never seen any signs of that, but he does have, I think, a diagnosis of bipolar on Abilify, and his paternal uncle was addicted to drugs and alcohol. So I think that covers everything. Try to go fast for you. So let's hit back on the questions. And if you guys have any questions about the patient, I actually know a lot more, but I don't want to belabor it.
Well, thank you so much, Dr. Morrison. As always a wonderful case presentation. I'm more than happy to pull up the questions again, but on initial thought, does anyone have any clarifying questions, comments, or thoughts for Dr. Morrison?
Ryan, I do. Do we know for sure that he actually had DTs? And the reason I ask is, okay, so this is just a teaching point. Frequently, people will get admitted to our services and say they've had DTs, or some doc will have said DTs, but it truly wasn't delirium tremens. And it just means that they got really, really shaky and had to be on a Ativan taper or something in the past. So it would make a difference if he truly had DTs as opposed to not, but sometimes we just don't know. But thank you then.
Thank you, Dr. Berry. Any other thoughts or comments? And we encourage everyone to speak up and unmute. It's a welcoming group. All right, and any feedback or recommendations for Dr. Morrison? And I can pull up the questions again if anyone needs to refer back.
I'd say number 2, is there a role for Camprol, antabuse, gabapentin, pregabalin? Camprol and abuse, definitely. The gabapentin, Lyrica, a little more dicey, especially if he's going to be on Suboxone. Just out of curiosity, have you ever discussed naltrexone with him to kind of do double duty, like Vivitrol, both for his drinking and his opioids? Sometimes, like, my brain goes in that direction, depending on the extent of their opioid use. But this is something kind of worth thinking about with him if he's kind of equally struggling with both.
I just mentally ruled it out, but I think that's a potential. How long would it take for him to be off Suboxone before he could realistically like trial a naltrexone tablet?
10 days, 14 days at the most. It's just something, I don't know. I mean, I try to offer it to people. I know with our CTN study, we're doing a little bit more Vivitrol outpatient, which is kind of nice. The other stuff, it is frustrating when some places won't do alcohol detox, and it seems like, or if they're detoxing, they won't give him Suboxone for whatever reason. Sometimes there's valid reasons for it, sometimes there's not. Managed transitions from AUD from inpatient detox back to outpatient. Again, it kind of, for us, what I've seen is usually just depends on the extent of how much they are drinking and if it's continuous. And it seems like with this guy, he has a lot of alcohol problems. I don't know. Would you argue that's his drug of choice is alcohol, fundamentally?
Yeah. Oh yeah, he would tell you that.
Yeah. Does a Suboxone calm that down at all? I mean, the other thing I'd say is if he wasn't drinking in a halfway house or a sober living, that might be something to try to encourage him to get back into if he was able to maintain sobriety there. It's kind of my thoughts with it. But yeah, absolutely. With the Camprol, starting that up, there's no reason you couldn't do that. You could consider Topamax and somebody like this too. He wouldn't be a terrible candidate for that, especially if there was some like meth on top of it or cocaine. So just something else to kind of keep in mind back
I want to point out that he and every patient I've ever had have said that Suboxone helps them to drink less. So I don't know if I'm being naive to believe that, but that's been my thinking, is that Suboxone does not trigger alcoholism.
No, it doesn't. I will say the only thing that would kind of be a red flag a little bit is, so he's bipolar and he's on Abilify. Abilify can make people more compulsive sometimes. So in addiction, a lot of times you'll hear not good things about Abilify. I know Gamblers Anonymous, they're not big fans of Abilify at all. So I doubt the Suboxone would trigger his drinking. Like you said, it probably would keep a lid on it a little bit. But the Abilify theoretically could be fueling it a little bit.
I would be strongly suspicious that he doesn't have bipolar. And I would be strongly suspicious that he may have PTSD given the history. And a lot of that can look like bipolar, and certainly drug use at a young age and recovery, et cetera, can look like bipolar too, or bipolar also, bipolar 1 or 2. And so just as a point of information.
Another thought is that if he's living with somebody who's in recovery, they could dispense antabuse to him and assure that he were taking it. So I like antabuse when you have somebody to make sure the patient's actually getting it.
And so totally agree with that. And sometimes what I'll do, Ryan, is if I have somebody who's a frequent relapser on alcohol, and by the way, I want to find out why you want to go away from the term relapse. I'm curious to hear those thoughts. I have somebody who is a chronic relapser on alcohol, or I'm worried about will start drinking again. I'll insist they take antabuse if they want a Suboxone prescription, and that they have to take both. And sometimes it's gotten to the point where they have to come in and we got to watch them take it. Antabuse is my hands down favorite medicine of all time, by the way.
Do you have a test that you can just like measure if they're complying with the antabuse?
If they're drink.
Like a breathalyzer.
Yeah, breathalyzer. Yeah. Or if they come in and they got a blood alcohol or ETG, ETS, and they're still positive, then, and if they say they're taking it and they're still getting sick, up the dose.
I think I might do something like if he'll just agree to take antabuse, let him go back to phase 1 now. Is that too assertive or aggressive?
No, I mean, it sounds like this guy had a good amount of sobriety. I mean, he had 220 days or something, so he was really getting it. And it sounded like he's pretty stable. The good news is it was only like 1 or 2 weeks, right, of being out there using again.
Yes.
And so, I mean, he demonstrated that he's able to do it. I think he just needs a little bit more help right now. And I would probably just put him back into the beginners and see how he does. You could always increase the level of care if he's struggling with that. Is he going to take Camprol too?
He says he will now, but he
So
says
what
it never helped him before.
Okay, and it might now that he's just stopped drinking. What I find is what I like about Camprol is it does seem to help a lot of my patients with the anxiety and irritability that they experience. You know, like even some post-acute withdrawal or just natural anxiety and irritability. So that's something that I like with it.
Should I encourage him to come off Abilify? I'm not the prescriber for that. I'm afraid to touch it.
Who is prescribing it? Is it a psychiatrist? Or is it... I would encourage him to see a psychiatrist and see if it's like you said, he might have PTSD combined with substance use at a young age that would probably be treated a lot better with something different. So I wouldn't personally just unilaterally say stop your Abilify, but maybe discuss it or have somebody else get a better idea.
I wouldn't worry too much about that right now. Right? I would try to work on getting him stabilized from his addiction standpoint and see where he's at, and then they can kind of follow up with that medicine with someone else.
I refilled it, but he was on it long term from someone else, and it looks like he's not following up. So I was trying to bridge it. So, but it was not from a primary care provider before. So.
What dose is he on of the Abilify, just out of curiosity?
Five.
That's not really even a bipolar dose of Abilify, quite frankly. That's more of a depression dose. So if you did have bipolar, it probably wouldn't be doing a whole lot to begin with. Just FYI.
Kristen is our pharmacist that I can see. Do you have any input on that?
Work in patient access, but I will prepare for next time. I took the ASAM virtual review course last week, and they talked a little bit about why we don't want to use the word relapse. And so I'm looking for that right now because that piqued my interest also. So I will get back to you.
My answer.
I'm sorry. Well, one thing about psychotherapy, so, in someone who's just stopped using a substance, you want to prepare for high risk situations. So what's the most likely trigger for a relapse for him? And how can he prepare for that so that he feels equipped to deal with whatever urges might come up as he launches back into sobriety?
And Phil, did you have a comment as well? I saw you had unmuted.
I was just going to encourage participation in psychotherapy to also kind of help rule some of this out too. If it's underlying trauma, working through the trauma and learning about his triggers a little bit more too.
Thank you very much. And Kristen, we're curious to know about the terminology relapse, but Dr. Morrison, were you going to comment on that as well?
So I can just tell you that for me, we are funded by the federal agency called the Foundation for Opioid Response Efforts. And it's the same folks that got me moving away from MAT and trying to say medications for opioid use disorder. They were they were at the level of, you're not getting funded unless you change this language. And so it's the same with recurrence and relapse. As I don't know the background, I just know that at the federal level that this agency is very language sensitive.
Yeah, I'll tell you the background is that, there's an effort to truly be sensitive to the language and destigma and all that. Some of this stuff, in my opinion, goes way too overboard, and it over medicalizes the disease of addiction or the disorder of addiction. And I'm comfortable saying disease or disorder, but it really gets into an over medicalization. It's the idea that that addiction is just like diabetes, which it's not. It is its own thing, and it's got, as Philip has brought to our attention, is it's something where you have to look at, biological, psychological, social framework, and relapse is part of what happens with addiction. And we have relapse prevention strategies, techniques, et cetera, and I don't have a problem with that. So it is what it is, but some do. And what else was I going to say? Oh, about the whole MOUD. That was a battle I tried fighting against for a while. I think that actually, if we would have called pain pills MAT, medication assisted treatment for pain, I don't think we would be in the problem we are in right now. And if we called, antidepressants MAT as well, or even insulin MAT, I don't think we would have, I think that would be a helpful thing. Again, it's recognizing that it's not just pills that we're giving people, but we're trying to do holistic care and trying to really get all domains involved. It's just so easy to go down the route of just writing a prescription and over pharmacolize a lot of disorders. There's my soapbox for you, Ryan. My soapbox moment. Enjoy.
Good.
I agree. Thank you so much for that take on all of that, Dr. Berry. It's very interesting. Dr. Morrison, did you have any other?
Thanks. No one else listens to me, Mithra, but thank you.
I love it. You always have a great, comment and everything. So we appreciate it. Dr. Morrison, anything else about the case before we transition to the didactic portion?
No, I just want to say that, yeah, more people should listen to Dr. Berry. And it is frustrating. It's really doctors in general are not feeling listened to at this time in history. But I'll let it go at that. There's my soapbox return. And I'll let Dr. Hirschman take over.
Awesome. Well, thank you all so much for the great recommendations and feedback and everything. And again, thank you, Dr. Morrison, for the case. We do encourage all folks to submit cases. We love having case presentations. So reach out if you need help submitting one. Dr. Hirschler, I'll turn things over to you. Let me know if there's any tech difficulty sharing your screen. And Dr. Hirschler, I have it on my end as well.
Can you share yours, Mitra? I'm having trouble accessing it.
Absolutely, yes.
I can't minimize my screen for some reason.
Oh no, you're totally fine. Is everyone able to see that okay?
Yes.
Excellent, thank you. All right, Dr. Hirschler, I'll turn it to you now.
All right, thank you. So Ryan's case is a perfect example, and really every case is a perfect example of how important addictions recovery is to the whole approach to a patient. And what I'm talking about here is what patients can do for themselves in their work in responding to an addictions problem. Next slide, please. So you guys all know WVU's different facilities, Chestnut Ridge, Ruby, the Center for Hope and Healing. Next slide, please. So ideally with recovery, you want the patient and the people who are involved in recovery to feel confident in the model. And so I'm going to try to display a scientific basis for recovery that we can be confident in and moving in that direction. Next slide. I have no financial disclosures. Next slide. So here's the core concepts that I'm going to discuss. I'm going to talk briefly about the history of the recovery movement. I'm going to talk about outcomes of 12-step recovery. I'm going to discuss complaints and controversies about the 12-step model. I'm going to talk about how we can evolve into a progressive, eclectic, and efficacious new model. I'm going to talk about what patients can do for themselves. And then I'm going to describe 3 domains of addictions recovery. And then I'm going to, after those are thoroughly described, I'm going to talk about the neuroscience behind successful recovery. I'm going to talk about the need for science and evidence. And then I'm going to talk about future prospects in the recovery movement. Next slide, please. So addictions recovery starts in the 1930s with Alcoholics Anonymous. And Bill and Bob developed Alcoholics Anonymous, and it's a fellowship of people focused on sobriety. And it's interesting that we've kind of stuck with this model since the 1930s in a lot of ways. And so I want to talk about how we can progress from there. Next slide. So what are the core concepts of recovery? Well, first of all, it's self-directed, it's empowering, holistic, it's non-linear, so there's continual growth with setbacks, it's strengths-based, peer-supported, and it fosters respect, responsibility, and hope. Next slide. So what about the outcomes of Alcoholics Anonymous? Well, since it's been around since the 1930s, you would think that there would be lots of randomized trials to look at, to investigate the efficaciousness of 12-step recovery. But actually, there's very few randomized controlled trials. And the few trials that have been done have compared something called 12-step facilitation, which is a psychotherapy that uses 12-step models and facilitates activity in recovery groups. And that's been compared to cognitive behavioral therapy and motivational interviewing. And several studies have shown that these different methods of therapy are relatively equivalent in efficacy, but they're not that powerful, that there's a lot of room for improvement and relapse rates are still quite high. There is some evidence that AA group attendance levels can impact the outcome, but eventually you reach a plateau after so much attendance. And so it is kind of a happy medium about the attendance in mutual support groups. Next slide. So what are the complaints or controversies about AA? One of the big problems is that people in AA may denounce folks who are using medications for their treatment of addiction, and but particularly people who aren't on medications, and they view medications as substitutions or replacements. And the science just kind of points to the obvious benefit of medications and treatment, and this stigma around medications is an issue that needs to be resolved in our recovery. And then a spiritual basis of AA is a problem for people. They have to have a higher power, or they're encouraged to have a higher power, and that may not appeal to many. And so what I'm suggesting is that a fundamental science of recovery is going to be reality-based rather than spiritually based. And then, like I was saying, it's kind of disappointing how rapidly technology advances. If we were using telephones that were still 1930s model telephones, that would be, amazing. But so why aren't we using kind of a more modern approach to recovery? And so I'm going to try to push us towards a scientific modern approach. Next slide. So we want to evolve into a new model. And historically, recovery has not been separated from the science of treatment. But actually, what recovery kind of shows is that we want to move from just studying pathology to also studying wellness. And also, patients in treatment often view themselves as passive recipients of healthcare. And recovery kind of encourages patients to get involved in their healthcare and be active members of their treatment. And so it's a different kind of philosophy about recovery from illness. And of course, we want to listen to our patients' needs. And so patients often come to us not just with a substance use problem, but with all the issues related to the consequences of their substance use or the factors that may have precipitated substance use. And so it's usually a complex kind of group of problems that a patient presents with. and their needs are complex, and often just focusing on a single pharmacologic treatment of an addiction process is not adequate. Next slide. So what is recovery? It's the sober and productive lifestyle of individuals who've successfully resolved dependence on alcohol or other drugs. And it's a maintained lifestyle. So patients are recovering or in recovery rather than recovered. And it means learning to live without using drugs or alcohol. And this means handling negative emotions without using alcohol and drugs, and being able to enjoy life without using alcohol and drugs. And Austin Brown and Robert Ashford, who wrote a beautiful article on addictions recovery, say that successful long-term recovery is a fundamentally emancipatory set of processes. And what they're talking about is that it frees one from the bondage of pathology. Next slide. So what is the addiction recovery process? And maybe put most simply, recovery is about taking care of yourself. But the Betty Ford Clinic had a panel of folks put their heads together and come up with a model that involves 3 domains. And those 3 domains are abstinence or incomplete abstinence, well-being, and giving back. And so I got that information from the Surgeon General's report on addictions, which is an excellent source of information about recovery if you haven't read that. Vivek Murthy was the Surgeon General then, and made a report on addictions, and it has a nice chapter on recovery. And so these 3 domains are the most basic elements of a successful recovery: abstinence, well-being, and giving back. Next slide. So how do we achieve abstinence? Well, first of all, motivation is super important. And every patient who recovers successfully has a why, a reason that they're getting help. And so you can ask the patient, how come you're here getting help? You know, that's their why. And it can be from escalating consequences of their substance use or other addictive behavior, pressure from people in their life, friends, family, employers, legal troubles, health concerns, wanting to be a responsible parent, they're tired of the lifestyle. But actually the majority of patients report that escalating consequences of substance use is their most common why. And that comes from Laudet, a group in 2002. Next slide. So also in abstinence, it's important to have emotion-packed goals. And that comes from the discrepancy between where the patient's life is now and where they want it to be. So that's what motivational interviewing is all about, is creating that discrepancy. And when patients have goals, they have to decide, you know, is this something I can achieve while I'm using substances, or are substances gonna be negatively influencing my desire to achieve these goals? And so that's an important role in abstinence. Next slide. Also, surrendering is important. And I view this differently than they do in Alcoholics Anonymous. You know, in Alcoholics Anonymous, they talk about surrendering to a higher power. I think that your surrender is about, this life doesn't work for me. You know, that using alcohol and drugs just isn't an option. It doesn't work. And so that kind of surrendering, I think, is a healthy surrender. So it doesn't have to be a spiritual surrender. Next slide. And then I was talking with Ryan about preparing for high-risk situations. So in abstinence, patients need a toolbox of approaches to deal with the toughest situation where they're most likely to relapse. And if they can prepare for that, they're ready for almost anything. And so that they can call someone who has a long period of sobriety, or find something healthy and relaxing and enjoyable to do instead of substance use, you know, like taking a warm bath or going for an easy walk or a relaxing drive, or a picnic or a dip in the pool, or stargazing or a yoga session, or going to a coffee shop. So there's lots of things that patients can do, and they can be creative about healthy activities instead of slipping back into a substance. Next slide. Also, social group reconstruction is super important in abstinence. You know, patients need to look at their phones and think, you know, do I have phone numbers in my cell phone of people who trigger substance use and I used with them, and they're my drug dealer? You know, they need to get the phone numbers out of their telephone and create a healthy social group around themselves. You know, people that are solid people who wish them well and support their sobriety, you know, not people who are going to be a negative influence. Next slide. And then along that lines, a good recovery environments are also important. And so Brown and Ashford in their article talk about recovery-ready communities. And so that means having recovery residences and recovery employment, recovery educational environments and drug courts and recovery-oriented community centers, peer recovery services like recovery coaches and community organizations and coffee houses and gyms and recreation centers. And then with all this recovery community, we have recovery capital or the resources to assist in recovery. And then the community can have recovery readiness, which is when the general perception of affected individuals and the public and the families involved, see that this is going to be helpful for them. Next slide. Also, stress recovery is important in abstinence. And stress recovery means having unwinding routines. So like today, a patient told me she works 3 jobs. She has no time to unwind. She's constantly working or sleeping, and there's no balance to her life. And stress recovery is super important in a successful abstinence and well-being with substances and recovering from substances. So you want a healthy unwinding routine. Next slide. Distress tolerance is also important. And so people with substance use disorders may feel that life is so unbearable it requires anesthesia. And often that grows out of psychiatric disorders or adverse childhood experiences. And so they need to kind of find ways to tolerate distress better. And the science of distress tolerance is largely investigated in borderline personality disorder. But we can kind of expand on the knowledge that's been gained from that field and kind of look at how to tolerate distress for people who maybe don't have that disorder, but still could value distress tolerance. And so softening into distress rather than resisting it, and having a dispositional joy. When you believe in something that gives you a dispositional joy, it could be a spiritual belief, but it could also be the belief in evolution, or the belief in some value that you have that's important to you can give you that calm, quiet, serene kind of sense. And then looking at distress as this too shall pass, kind of just easing through the distress by expecting it to end. And then you can detach from distress with detachment, just to withdraw a little bit from the distress. And stress inoculation can help with distress tolerance. Basically, what stress inoculation says is that stress makes us tougher. And so it's like an inoculation, like a vaccine, that when you're exposed to a vaccine, your body gets resilient. And it's the same way with stress. As you're exposed to a stressor, your body kind of ushers up resilience against the stress. And then the next time you're faced with something difficult, you're like, oh, that's not so bad. I've been through so much. And then also frustration can be viewed differently. So some people respond to frustration with anger and being destructive, but frustration can also be a source of discovery. And so if you look at frustration as an opportunity to solve problems and be creative, and have that framework for frustration, it can really reduce stress. And then also differentiating good pain from bad pain. So good pain is like fitness-related pain, whereas bad pain is pathology-related pain. And so if you can expand upon the concept of good pain by finding a silver lining in distress and pain, if there's something beneficial about this experience you're having, it kind of takes the power out of the pain. Next slide. So also healthy activities and hobbies are good for recovery, employment and education. And the most important thing about this, it builds self-esteem and ego if you have a job and you're working on your education, but it fends off idle time and boredom. And when patients say they're bored, I always say, goals are the antidote to boredom, not entertainment. And so if you can come up with some goals that you'd like to be working toward, that makes life fulfilling and enriching and thinking about how you can better your life. Next slide. Now, maybe the most important thing about recovery and abstinence is what Ashford and Brown call radical shifts in identity. And so we were talking about stigma and the language of stigma and how that impacts recovery. You don't want to have a stunted identity. And so it's who you become that matters most. And so when you think about someone recovering from smoking, it's the shift a person makes from thinking of themselves as a smoker to thinking of themselves as a non-smoker. And so when they can make that shift, I think that shift in identity helps with recovery. Or think about the person who thinks of themselves as a pothead. And that kind of reinforces more and more substance use. And if they can take on a strong and distinctive identity instead of maybe a stunted identity, I think it really supports good functioning. And so Eric Rankin, who used to work at WVU, said that identity comes from your lovability and self-worth. But I also think it comes from love, work, and health know-how. You know, that if you have some know-how about how to thrive, that can really help with identity. And you identify with those ideas and people that you admire. Next slide. So also recovery schemas help with abstinence. So these are just ways of viewing things. So I've got something to prove. I'll thrive in spite of them. I love life. Living a good life is the best revenge. I hope God believes in me, or you bring out my best. So when there's a schema that kind of supports a good recovery program, that can be helpful in abstinence. All right, so let's switch gears to well-being. Next slide. So well-being to me is about love, work, and health. And how do you get there? 15 minutes. That you can get there by an assembly of discrete parts, by a growth of systems, by mitigating problems, and achieving health confidence, or love, look well, feel well, think well, and do well, and flourishing. And so flourishing is about the reality of love, work, and health. Next slide. So what do I mean by the assembly of discrete parts? Well, that means things like the right food and fitness and good sleep and a strong mindset. So a strong mindset, like having a stubborn hope. I always tell patients, you know, I've got a stubborn hope. I'm going to persist at this and see what I can do to help them. And have a taste for challenge and to overcome oneself. Be humble and conditional optimism. And then mental toughness to cultivate great self-talk and visualization. And manage the distractions that interfere with working on your success in life. And caring and cooperation and being trustworthy. Gliding well socially. Building a favorable reputation. Having financial security and a secure home environment, and having a sense of purpose. You know, purpose is so important in well-being. And then building beauty into one's life, you know, making something beautiful of your life is a part of well-being. Next slide. And then what about the growth of systems? So we human beings grow. And actually, I think that growth occurs in response to the environment. So if you want to impact someone's growth, you should impact their environment. And it's really the genes and environment interaction that we talk about in medicine. And so you want to create an enriching environment that supports the natural growth of an individual. And so you don't want to be passive about your environment. You want to make it great. And so I always talk to patients about their recovery environment and, you know, how enriching is your environment, or is this kind of a negative influence, your environment, and destructive? And what can we do to improve your environment? And actually, Prochaska and DiClemente talked about natural recovery, and they said it occurred in stages, you know, pre-contemplation, contemplation, preparation, action, maintenance. But actually, I believe that natural recovery occurs in response to your environment. You know, it's a growth process in response to a healthy environment that develops natural recovery. And so Prochaska and DiClemente looked at smoking cessation and said, why do people who stop smoking stop on their own, you know, without any help? And so I think it's a natural recovery from the environment that plays the biggest role in that. Next slide. And then mitigating problems is important in well-being. And so you have to learn to manage the drama of life and the psychological games that people play and all the distractions about interfering with what's most important. And ideally, people can become problem seekers and not just problem solvers. You know, if you can get the attitude that I'm excited about finding problems and improving things and bettering my life and other people's lives, you know, that kind of attitude really supports well-being. Next slide. And then health confidence, you know, I think that comes from looking well, feeling well, thinking well, and doing well. And there's lots of components to health confidence. You know, the look in someone's eye and their gestures and postures and the way they walk, and feeling well, you can detect from someone's emotion tone and their voice. So when I talk to patients in the Coke clinic, I often pick up on their emotion tone and will comment, that you sound a little distraught. You say you're okay, but your emotion tone maybe isn't so positive, and what's happening there. So thinking about how you feel based on what you display to other people. And then thinking well, so I think know-how is important, as well as mitigating problems and constructing a flourishing life. And then doing well really boils down to thriving. Next slide. And then lastly, so we have abstinence, well-being, and the last aspect is giving back. And so that involves community service work and helping others. And particularly when you help someone who's in early recovery, that kind of gives the patient a transcendent feeling, to be a support for someone else. And so I encourage patients to help others in early recovery, especially if they've got some sober time. If somebody's early in recovery, that might not be the best thing to be working on because it could trigger their own use. But for someone who's got some sober time, it's good to be helpful for other people in early recovery. And then citizenship, being a good neighbor, respecting the environment, voting, and then giving back creatively. I think ideally, if you can be creative in your giving back, that's really an important aspect of well-being. Next slide. So why does all this abstinence, well-being, and giving back work what's the scientific basis of this for a successful recovery from substance use? And basically, it's about neuroplasticity. And so neuroplasticity says that the brain gets good at what it practices. And so if the brain is practicing abstinence and well-being and giving back, it gets ingrained. It's a self-directed neuroplasticity rather than just kind of responding to your environment and just doing whatever feels right, where the environment has total control over what happens neuroplastically. You can have a self-directed process. And the other thing is that there's something called competitive neuroplasticity, where if what you're practicing is healthy and your brain gets busy, occupied, working on healthy functioning, it kind of competes away the pathology because there's only so much cortical real estate in the brain. And so if the brain is occupied doing healthy functioning, it competes away the pathological stuff that's going on, just out of disuse and the brain not developing in that way. So that comes from Norman Deutsch, who's an expert on neuroplasticity. Next slide. So this is an important kind of theoretical principle. It's psychologically easier to build a new healthy behavior than to simply rip out a problem behavior as though it were a weed. So this also kind of supports the importance of well-being and giving back as a part of healthy functioning and not just working on abstinence. Next slide. So how do we develop a fundamental science of long-term recovery? Well, we have to have evidence-based outcomes. And so you have to figure out what you're going to measure. And I think, we don't want to just measure days of abstinence. And, the literature is kind of supporting looking at quality of life as an outcome to measure in addictions. And I think well-being becomes an important part of quality of life and figuring out how we can measure well-being and even giving back as well as abstinence. How do we measure those well? And Peter Drucker, who's a famous business expert, says you can't improve what you don't measure. So we got to think about what we're measuring in this field. Next slide. So what's the future of the recovery movement? Well, I think it's advancing things, advancing love, work, and health know-how across the lifespan, and advancing abstinence, well-being, and giving back. All right, next slide. You'll see my references. So any thoughts about this? Can we have a discussion about recovery? What do you guys think?
Well, first and foremost, thank you so much, Dr. Hirschler. That was a really impactful PowerPoint, so we appreciate it. And a lot of great things going on in the chat over there. I'll be sure to include all those great resources Dr. Berry shared in the recap email. But we have about 5 minutes, so anyone with any comments or questions for Dr. Hirschler, feel free to unmute.
So I'm definitely a 12-step advocate. I think it's appropriate for patients as healthcare providers. We do not go home with patients. We don't talk to them on a daily basis. We send them out for therapy, but even that is not a 24/7 job. and 12-step recovery programs have people who are available 24/7. The key is emphasizing the long game of why they're important, because if we only require or encourage 12-step attendance early in recovery, and then we never ask about it, patients may think it's not important and they do step away. And then when life happens, a pandemic happens, just something happens, then they don't have a support network other than the team, which again is not 24/7. That Cochrane article did, have a lot of reviews of other articles that showed that AA was more effective than CBT. We did talk about in the chat that the people that attend don't necessarily practice the principles that they preach, which is why investigation of multiple groups is really important to encourage.
Question on the Cochrane review in terms of manualized versus non-manualized, the tough word. I mean, how many programs are, more standardized or not? I think that's a question as well. Because I do think, unfortunately, there's not a lot of great evidence. This is actually the first kind of, Cochrane that supports that, but it's a really tough thing to study. And many of the things that we do in addiction, people study for very short periods of time. And so I guess, any comments on that, on kind of standardized versus non-standardized, because that's my understanding of manualized. And if it's incorrect, please correct me, because that's what I was trying to figure out.
Yeah, take a look at that, Dave. I mean, it includes both. And it's a very lengthy Cochrane review, and it's, really, it's probably one of the best Cochrane reviews that I've seen. And, arguably, more evidence than the majority of what we have in addiction supports this stuff. So take a look at that and see what you think.
Thank you, Dr. Herser, for the presentation. That was really great. One of the things I was thinking about as you were talking is, all these things that you talked about are wonderful. They sound wonderful anyways. How do you build that, as we heard from somebody else, how do you build that structure in so that patients are getting enough exposure to it for a long enough period of time to start to build the skills, the emotional skills, the internal skills, the life skills, to build more safety in their life so they can go out into the world and actually live their lives? I was thinking about that as you were talking. I don't know if you have any thoughts on that, or.
I think it's an educational component. So, part of it is practice, but patients have to be exposed to the ideas in order to develop them. And it requires some initiative on the patient's behalf to learn these processes. So, and we can encourage things in our work with patients, like the identity aspect, or all those different kind of aspects of healthy functioning, and what ways to promote abstinence can be exemplified in our work with patients as we work with them in groups or individually. I think we need it'd be great to have a manual of an evidence-based science to recovery that's solid, and I just think we need to do more work on this area.
Yeah, I wholeheartedly agree, and I really like the tact of trying to really get at quality of life, and how do we best measure quality of life as we're helping folks and looking at various interventions. And we just don't do a good, and it's not just addiction, but healthcare in general. We don't do a great job of that.
It's just as a comment, it's similar to, when they tried to look at, and actually Cochrane and other people tried to look at management of labor in Ireland, and what they call active management of labor. And there's, many things that they did during that, where here in the United States, we tried to say, oh, it's early rupture of membranes, or, oh, it's high dose of Pitocin. and a lot of these things in recovery are the same thing. Is it may, you know, what's the essential package, or is it the total package? And I do think it's very hard to study, but I think we need to. And you're right, it's looking at the long one, you know, and, you know, is, you know, self-help, you know, 12-step programs essential, or are they a very good tool? What are some other tools? And I think that's the challenge, is to figure out. I think there are very, you know, different people with different experiences and local resources as well, that, you know, what's essential and what's useful. Because yeah, I think this, you know, Dr. Berry, to see I think that's pretty impressive. Clearly makes me relook at some of that and go back at it. But I also think it's tough to figure out what the package is, since we all deliver slightly different packages, I guess, of recovery. But I think clearly to have a supportive community, I don't think people can do it regardless of what that community is, whether it's their family, whether it's their work, whatever their, you know, whether, you know, it's their recovery community, which I think is the one that understands them the best. I think other people have difficulty. We've tried to recreate some of those, but yeah, it's true. So.
That Dr. Baltiera. Did anyone have any other thoughts or comments for the group? Alrighty, well, thank you all so much. This has always been a great session, but we appreciate each and every one of you. Dr. Morrison, thank you for the case, and Dr. Hirschler, thank you so much for that didactic. Got a chat in from Dr. Berry saying great lecture, so thank you all so much. The only announcement that I have is that our next session will be on August 9th, and Dr. Zhang will be discussing meth and Suboxone use. So keep an eye out for that reminder, and we'll see you all next time. Thank you.
Thank you, everyone.